everybody. I'm David Katz, and this is a new experience for me to be chairing one of these meetings in a Zoom context. It's a new experience for all of you to actually get to connect with the association in this kind of way. And we're hoping that it's going to be, first of all, a successful event this evening, and it's going to be a good beginning to several such opportunities. We've already got some planned, and we'd like help and advice from you in future planning. The precipitating cause of this is, of course, COVID-19. And one of the issues is that, of course, it's changed a lot of our work, a lot of our activities. Some of the people on this call have been involved heavily on a day-to-day basis at the coalface. Others, like Ellis and myself, have been involved in doing things in the background. And it's been a privilege to get to know Ellis better and to hear his ideas and advice in our role in the British Medical Association, where he's been an important public health advisor. He's also working as the treasurer of the Faculty of Public Health. And in that capacity, he was responsible for an interesting article resembling tonight's topic, which appeared recently in the British Medical Journal. You hope you're going to bear with us, and that neither of us are greatly experienced in running Zoom meetings, so I hope there are not going to be any glitches along the way, but we're going to do our best to actually do this in coordination. It's a little bit like the blind leading the blind. But anyway, I'll hand you over to Ellis, and I'll ask him to carry on and give us his talk.
Well, thank you very much, David, for that introduction. As you've heard, this is, if you like, the relaunch of the Jewish Medical Association as an online discussion group. And this is the first in what is hoped to be a series of talks about the COVID-19 pandemic. Now, it's obviously a pity that we don't have the usual kosher meal that we're all used to on these events, but I hope to provide some food for thought and discussion tonight. And as you've heard, whilst I have an official role in providing regular advice, both to the BMA and to the Faculty of Public Health, and occasionally to the Department of Health as well, the views in this talk are personal and don't necessarily represent the views of any of those three organisations. Now, I've agreed to give this talk at relatively short notice, and whilst this might excuse my lack of slides, and I have to admit that David and I aren't quite sure whether the two slides I've prepared we're actually going to be able to show, but let's hope that we can solve that technological puzzle. But more importantly, it helps ensure that my comments are more likely to have relevance in a fast-moving topic. I intend this evening to make some tentative judgments about the handling of the pandemic in the UK, especially in England. Now, on June the 9th, there was an NOP poll which found that the UK had the worst public perception of the handling of the pandemic amongst a group of 30 nations. And so in the first part of my talk, I try to address the question, is this perception justified? I will tell you some of what I said at the time about some of these issues. I've commented on many aspects of the handling of the pandemic, both as a so-called BMA expert, but we'll concentrate tonight on giving an overview of how we've handled the epidemic up to this point. Or, as Churchill might have said, it might not be the beginning of the end, but perhaps it is the end of the beginning of the pandemic. I'm then going to look ahead to set out the pros and cons of 4 strategies to maintain the suppression of COVID-19. And hopefully, by both looking back and looking forward and talking in relatively broad terms, with a little bit more specificity for some of the questions I've been asked, that will be a good lead-in to what I hope will be an interesting series of lectures. So I should add that I have known, often for many, many years, some of the, what I will call dramatis personae, who feature in the regular daily press conferences, which I'm sure many of you will have seen. They're normally held at 4 o'clock each day. In particular, I know John Newton, Jenny Harris, JVT, and Yvonne Doyle very well. Some of them I've known for 30, 40 years without giving away my age. Obviously, I will keep confidential, or try to anyway, some of the information that I have been given, because it's privileged, of course, by some of the people that I've mentioned and some of the organisations that I've mentioned in my opening remarks. But I would want to say that for those of us who have been in public health for all their professional lives, including some of the people I've just mentioned, what the pandemic has undoubtedly done is made people realise some of what public health does and its importance. And that actually is not something that I could take for granted during much of my professional career. I also would start off with what I call a health warning, which is, before starting on my summary judgment, I should add that it is standard public health practice to wait until the end of an outbreak before undertaking a lessons learned exercise. It is said to be imprudent to make summative judgments in the midst of an epidemic. So forgive me if I ask you in making some judgments now to regard my views as tentative. So the first question I pose is how well we're doing, and I'm going to consider this issue under 11 headings, and I'm going to ask my glamorous assistant, otherwise known as Professor Katz, to see whether he can get the first of the 2 slides up on the screen so that you can see what those 11 headings are. I'll keep talking while he endeavours to do that. So the overall measure of how well we are doing, I would say, obviously as a health person, is the issue of deaths. And as many of you will know, there are 3 measures of deaths which are looked at. First of all, there is the COVID-19 confirmed deaths. Then there is the COVID-19 deaths which are mentioned in death certificates. And then, probably the most important measure is the age-adjusted all-cause excess mortality. Now, each of those 3 measures of deaths give us different numbers of deaths. So as of this morning, to the nearest 1,000, there were 42,000 COVID-19 confirmed deaths. There were 52,000 COVID-19 deaths mentioned on death certificates, and there were about 64,000 excess deaths, age-adjusted all-cause mortality. Now, all of these, when we compare our experience in this country to the experience across the world, demonstrate that we have arguably the worst, or certainly amongst the worst 2 or 3 death rates per million in the world. Now, it is still possible that because many other countries have less reliable reporting systems than in the UK, and some countries frankly have very unreliable systems of recording death, it is possible that my view about how well we're doing in the first wave of the epidemic in relation to deaths may overstate how badly we have done. It could just be that some of the countries, let's say in Western Europe, it will turn out in retrospect, have had more similar death rates than it appears at the moment. Having said that, there is really no doubt at all amongst epidemiologists that when you compare how we've done against many developed countries in the world, we undoubtedly have done much worse in the first wave of the pandemic. And some of those countries will probably be well known to you. Taiwan, New Zealand, Germany, South Korea, China. All of those have done substantially better than this country. Now, we can also say that or at least some of the experts advising the government thought we would do better. So the chief scientific officer predicted that 20,000 deaths would be a good result when he spoke in March. And clearly we've already, just in the first wave of the epidemic, had twice that number of deaths. Now, it is of course true that if we'd had no lockdown at all, then according to some of the modelling that has been done, let's for example take the modelling done by Professor Ferguson, who many of you will have heard of, then probably our death rate by this stage would have been of the order of 250,000. So clearly the lockdown has done some good, in fact quite a considerable amount of good, but it means that in comparative terms we've done much less well than many other countries, and therefore I have to rate our performance as being poor. Now, one of the things that we might have done is to have instituted a similar lockdown as we did do, but earlier. There is also an argument to say that the lockdown could have been stricter, as indeed was the case in China, Spain, Italy and France. But that probably has made only a minor difference compared to when the lockdown actually started. Now, hindsight is a wonderful thing. And there were many epidemiologists, including perhaps SAGE, although I don't think we're certain about what the SAGE advice was at the time, but there were many who were of the view that the lockdown at the time might have been timed correctly. However, there were many other epidemiologists, including myself, who contemporaneously were calling for the lockdown much earlier. I called for it 1 week earlier, and actually, personally, my wife and myself started our own lockdown 9 days before the official lockdown started. So why, in simple terms, did I and others think that an earlier lockdown was justified? Well, fundamentally, it was because we already knew what the experience had been in China, Italy and Spain. And by relatively simple looking at their experience would have indicated that it was justified to have started the lockdown earlier. Now, there is an argument that has been advanced by some that if we had instituted a lockdown earlier, we wouldn't have had the necessary degree of public compliance. That the public, in other words, would not have accepted the advice in sufficient numbers for the advice to have worked. I really think that that is highly unlikely. The reason? Well, clearly, many of the public will have seen the scenes of what was happening in China, Italy and Spain. And as I've said, I'm only suggesting that we would have started at a similar time as Italy and Spain. And their lockdown was accepted very readily by the population. So I don't really see why a policy which worked well in Spain and in Italy would not have worked well in this country. So I think again, there's little doubt, and clearly Professor Ferguson has already said so, that if we had started the lockdown earlier, we'd have saved many lives. Conservatively, at least 25,000 deaths would have been prevented, and probably considerably more than that. That again is a figure that Professor Ferguson has put into the public domain from his modelling. There are a number of models that are being used at the moment, but Professor Ferguson's is one that has had a great deal of influence with the SAGE group. So now let's go on to personal protective equipment, or PPE, as most of you know it is generally abbreviated to. Now, it is quite certain that stocks were in short supply. And there was, for many weeks at the start of the epidemic, there was a shortage of supply in many healthcare settings and certainly in many care homes. And clearly that may have led to deaths which otherwise would not have occurred, including 2 health staff, including many doctors, of course. Now, the truth is that we had little local manufacturing capacity. And although some stockpiling had taken place in the period from January to March, what it meant was that as we went from March into April, we were struggling as a country to cope with the replenishment of stocks. Now, it's also well known now that there have been exercises, albeit based on a flu pandemic, which were designed to test our preparedness. And in broad terms, many of the recommendations from those exercises were not followed. And clearly, in retrospect, that was a bad mistake. Now, probably the major reason the recommendations were not followed was because of the general austerity regime that the NHS and indeed Public Health England were following. And so, because some of these recommendations were relatively costly, that's probably the reason why they weren't instituted earlier. But again, one has to say that the lack of PPE was poor, and compared to some other countries, we did much worse. Now, the testing capacity, unfortunately, there is a relatively similar story. Again, we had little local capacity. We were quite good in the development of the test, but basically we had little local laboratory capacity to expand the service. And so, as we moved into April, we were forced to prioritize our policy, not based on what would have been the best practice, as famously Germany were able to do, but we had to base our prioritization of basically just doing testing in hospitals, because basically we didn't have the capacity to do more than that. Now, of course, you might say, well, why didn't we try to get more testing, and for that matter, more PPE from elsewhere? And the answer to that is that there was an understandable parochialism amongst countries who were all competing for very little availability of both PPE and testing across the world. And that testing and PPE that we got, we were paying enormously more for getting it than had been the case a couple of months earlier. But it could be argued also that it took quite a bit of time to galvanise the system within the UK. But again, overall, I have to mark us down as not having done well in respect of testing. So now at last we come to an area where I think we can say that we did reasonably well, and that is hospital capacity, including ventilators. There was a justifiable concern that the NHS could have been overwhelmed, and we weren't. There always were spare hospital beds and spare ventilators. And indeed, the Nightingale hospitals, which were planned and opened at considerable speed, gave us additional capacity, which fortunately was barely used. We also were successful in getting a lot of retired staff to volunteer to add to our capacity. And therefore, I think we can judge the NHS response to have been good. However, the reason why I put a slight question mark over how well we've done is by turning to the next area of care homes. Because what happened in the hospitals was that there was an understandable edict from Simon Stevens, which basically said, we need to free up as many beds as we can in the hospitals because of COVID. And part of that instruction was to try, where possible, to discharge people from hospitals into care homes. Now, that never included discharging people from COVID positive parts of hospitals. However, one can also say that there was some justification in health terms of it being prudent to move patients from the hospital to care homes, because hospitals are a site of nosocomial infection, and in other words, it was reasonably likely that people in hospital could have caught the infection there. Now, it is quite clear that some asymptomatic patients, having been discharged, will have caused some of the deaths in care homes. Now, that's unfortunate, but I think if that was the limit of what had happened, I think it wouldn't necessarily have been judged to have been a mistake. Because there are other reasons why care homes have experienced high levels of deaths. The lack of personal protective equipment, the lack of testing, the relatively poorly trained staff in control of infection procedures. But unfortunately, I know that there is some evidence that there were people who were discharged from hospital who had symptoms compatible with COVID-19 and had not been tested. Now, in those cases, there clearly was a risk that the people had indeed got COVID-19. Now, it is not possible at the moment for me to say how often that happened, but clearly those people who are saying that there were cases where people should have been tested because they were symptomatic before being discharged, there is at least some truth in that accusation. How large the numbers are, I don't know, and I think that will have to await the public inquiry we will undoubtedly get before that judgment can be made. Now, how well have we done, or how poorly have we done in care homes compared to other countries? Well, we can probably best compare ourselves to Western Europe, who have relatively similar policies in terms of care homes, and we've done broadly similarly in terms of the rates of deaths in care homes compared to other Western European countries, or sorry, in the Western European countries I've just mentioned, not in places like Germany. Now, I then move on to what I'll call the Cummings Affair. Now, almost every expert I know, and clearly myself, concluded that Dominic Cummings repeatedly broke both the spirit and the letter of the guidance. I'm not going to go through the very long list of all the contraventions, but safe to say that there is very little argument about any scientists or doctors conversant with the rules about the fact that he broke the rules. Now, undoubtedly, this has led to reduced trust and decreased compliance from the population. And clearly, as compliance in the population falls, one's ability to manage the epidemic falls alongside it. And so the management of that affair has clearly damaged public trust, and therefore one must mark it down as being a poor handling of the affair. Clearly, I'm sure the Prime Minister would say there were mitigating factors. I won't go into that. The economic plans. Now, here I think that there has been, not just in this country, but abroad, a general belief that the plans of the Chancellor of the Exchequer to support workers and businesses during the lockdown have been generous and have been reasonably fair and have generally got a good press across most of the world. Now, of course, I comment on our good performance in an area where I'm not an expert, I'm not an economist, but I would submit that there has been a general view, supported indeed by public perception in this country, that our economic plans have been good during the lockdown. Now, my 10th area is research. And this is an area, again, where I do find, well, I say again, it's the second one where I have come to a conclusion that our performance has been good. The government has funded and supported many clinical trials, including vaccine development, and has fostered international collaboration. It has also funded, to a very large extent, trials and international work. And I think we can rate the performance good in this area for that reason. And then finally, the clarity of the messaging. Now, I think the initial messaging when we went into the lockdown was, I think, reasonably good. However, many of the aspects of messaging and the individual policies that have been introduced in more recent times as we've moved into the phase, the relaxation of lockdown phase, I'll call it for the moment, those messaging efforts have been quite poor. And because community engagement is vital, this problem with the messaging has been a difficulty. And there seems to be a difficulty both in giving clarity of message, but also in giving nuanced messages. So, for example, some of you will know about the bubble that has been created for people living on their own to share a household with others. Now, if those people are at low risk of getting severe morbidity or dying as a result of contracting the disease, that is sensible guidance. But for people who are elderly or have underlying conditions, then they should be made aware of their individual risks before taking the chance of meeting with another household. And that sort of nuanced approach, which is based on a risk assessment, that has been a failure, I would say, of the government. So, overall, what is my tentative conclusion? It is that the public perception that we have handled the initial phase of the epidemic poorly is, I think, justified. Now, today, some of you might have seen Richard Horton, who I suspect most of you will know is the editor of The Lancet, on Breakfast TV. I told you this would be an up-to-date talk, and that's part of my evidence for that. He has just written a book, and he was basically plugging the book this morning, but in effect, it has covered the same issues as I have just run through briefly, and he has basically come to the same conclusions as me. In other words, that we have handled the outbreak poorly thus far. Indeed, I would say that he has been even more critical of the performance, particularly in England, than I have in my tentative conclusion. Okay, so I now want to turn on to a consideration of the, I'm just losing my place here. I want to move on now to thinking about how we might handle what I call the maintenance of suppression of the virus phase, but what is more normally called coming out of lockdown. And as you will learn soon, I have serious doubts about the prudence of the government approach, particularly in England, which I'm going to explain by giving a quick critique of that approach, and then I will set out 3 alternative approaches. Now, the current policy, I should hasten to add, might work. And obviously, like everybody, I hope listening to this talk, we all hope that it does work, because clearly that is going to mean that we reach a desirable conclusion quicker than might otherwise be the case. However, my view is that there is a realistic chance that we might have a second peak of some size. So, the critique I'm going to give is relatively similar to that which you may have heard Professor Edmonds, a very well-known epidemiologist who is still a member of SAGE. It is a similar view to the one that he has also put forward. So let me try to outline why we both feel that it may have been imprudent to undertake lockdown, particularly as has been the case in England. So the government is introducing a large number of new measures to the lockdown, which it recognises all of them will lead inevitably to some increase in the R value. Even if the mitigation measures, for example, in the workplace and schools, are followed. And it further recognises that it has little room for manoeuvre because the R value is estimated to only be just below 1. Now, we are attempting in this country to ease a lockdown when infection levels are still high, perhaps as many as 5,000 new cases a day, which represents a far higher level than any country that has successfully relaxed its lockdown procedures. So we have an incidence of the disease when we started the lockdown, which was about 10 times higher than that in Spain and Italy, right? Which is part of the reason for being nervous about the prudence of what we're doing. Now, there is much evidence, especially since the Cummings incident, of a lack of concordance from the public to the guidance. The messaging has been unclear, and some people clearly resent their perception, which is that there's one law for the political elite and another for the public, and they have acted accordingly. Now, we also have no reliable early warning system for the key metric of the number of new cases. The prudent step of deferring lockdown until we had a proven contact tracing system has not been taken. And of course, just yesterday, the WHO specifically agreed with that view, which I first expressed, let's say, 4 or 5 weeks ago. And it is strange indeed that the government, because it was quite feasible, didn't decide to introduce the contact tracing system earlier. It appears, and perhaps this is because Matt Hancock is such an advocate for new technology, that he was perhaps seduced into thinking that the app should be the major component of the contact tracing system. And of course, we now do not have a viable app, and we're not quite sure when we will. Anyway, clearly, for whatever reason, we decided to start relaxing the lockdown before the contact tracing system was in operation or fully operational. And as I've said, there was no proven app, there still isn't. The staff are mainly inexperienced, and the scheme is probably of insufficient capacity. I know that 25,000 is often said, which is roughly the capacity of the people working the system. It sounds large, but actually, one case in South Korea resulted in 31,000 people being traced. And so you can see that we can't possibly undertake contact tracing to the level being carried out in places like South Korea or New Zealand. Now, the other major control system to be introduced, which has only just been introduced, was quarantining. Now, that has been introduced in a haphazard manner. As again, some of you will have seen, the correct way in public health terms of introducing a quarantine system is to quarantine people at the port of entry or near the port of entry. That's what New Zealand are doing. In this country, we had the absurd, frankly, policy of saying you come to your port of entry and then you travel to your household of choice. And then we're going to trust you that you're going to obey the rules. Now, that is very risky. And it clearly means that people who are chosen as a household, they are also very likely to also get the disease if the person coming into the country is infectious. By definition, people in a household are close contacts. And usually, and it seems to be roughly the case with this epidemic, that about 80% of close contacts in a household will get a disease, an infectious disease spread by the respiratory route. So finally, there are no published trigger points for reversing the lockdown measures. Now, this is perhaps a more subtle point, but it is always considered to be good practice to, before you run into problems, you have said what will trigger action. Because otherwise, there can be a tendency to try to wait a bit longer before taking action. So, for example, let us assume that the R rate moves between 0.9 and 1.1. Well, there's probably going to be a range of different models giving slightly different views. Now, if we'd said that if the average of R is 1 or higher than 1, or if we've said that if the confidence levels go above 1, that will trigger action, then that would be clear and unequivocal. But when you don't have a trigger point, then you might very well think, oh, well, let's just wait another week or two before taking action. And with a virus like COVID-19, that could lead to very, very many more new cases occurring in a second peak. And that's why it is critical that there are no published early warning signs. So you can see why I am worried by the government's policy. Now, it's true that since that policy started, there has been a gratifying fall in the incidence of the disease. So thus far, you know, things seem to be going reasonably well. So I don't want to be too alarmist about saying that there is going to be a second peak. And whilst there will undoubtedly, and there already have been, local outbreaks, for example, there have been 2 in the southwest of the country, which I think are in the public domain, both in hospitals, there is a reasonable chance that local outbreaks can be managed locally. And that is the government's policy, and that is a sensible public health policy. So now let me go on to discussing 3 alternative strategies. Now, the first one is relatively simple to explain. And I don't know if we're going to try and do this, the second slide, but we might as well have a go, David. So the second policy is basically to have started with the outdoor relaxation measures, but not to have started the indoor relaxation measures for, let's say, about 4 weeks after they were actually started in England. Doing that will have meant we would have had assurance that the incidence of the disease would have fallen substantially. It would also have meant that we would have had a more proven contact tracing system in place, and we would have made some inroads in terms of the quarantine policy, flawed though it might be. So if we had done that policy, which again, I had called for actually as early as May in my advice, some of which was taken by the BMA, much of it was taken by the BMA, but not all of it. And some of it was actually taken by the Department of Health, but not all, as you can see. We would clearly have had a situation where we would have had much more assurance that we would have been able to cope with the lockdown measures at lesser risk. But we haven't done that, and therefore clearly there is more risk than has been the appetite in almost all the other countries in Western Europe. But clearly there are examples, like for example Brazil and America, who at least in part are taking more riskier action than has been the case in this country. So let me now talk about two further policy options which have been less publicised and which I think are both interesting and practical. So the first one, which I haven't managed to convince the BMA should be their policy, but is now gaining increasingly getting acceptance in this country and already has quite a lot of worldwide acceptance, is what I would call the elimination policy or the maximal suppression policy. And basically what one is trying to do is to emulate the position already achieved to a large extent in China, Taiwan, New Zealand and South Korea. In other words, a situation where basically there are no new cases occurring in the community, right? Clearly there will be some found which have been imported, which we find through quarantine. Now clearly the countries I've just mentioned, some of those managed to contain the virus in the first phase, but others like China and New Zealand achieved that desirable goal of maximal suppression of the virus through very strict lockdown, targeting hotspots, having extensive testing, a very strict quarantine rule, and clearly social distancing at 2 meters, as has been the case in this country. And there is little doubt that we could follow such an elimination strategy in this country. It looks unlikely given government policy, but we could still do it. Now, before the government announced its relaxation measures, and as you probably can gather, I work from home, unpaid, I should say, for the BMA faculty and others. And so my modelling, which I do from home, is clearly much less sophisticated than that of the roughly 13 modelling groups that put advice into Sage. But by my relatively imprecise modelling, we would have achieved by August that desirable goal of having eliminated the virus from the country. Now, you might say, and you would be correct, that such a policy would have caused greater short-term economic damage. There's no doubt. We would have been in lockdown for longer. We would have been able to relax measures outside the home because there is very little evidence of risk when one is outdoors. But the indoor measures would not have started. However, having achieved the desirable endpoint, we then could have had very, very substantial economic, social, and health benefits thereafter. Not that anybody in China, South Korea, Taiwan, or New Zealand are claiming that they won't potentially get new cases. They have had the odd new case, but life has returned almost to normal in those countries. And so this is a viable way forward. And indeed, just to show how current this is, this policy was put forward this morning on GMTV by both a professor from New Zealand, well, of course, he might say that, mightn't he, because of their success, but also by one of the public health professors in Edinburgh. He also made the further point, which I've been making for 2 or 3 months, which is that the UK has an advantage, which New Zealand shares, of being an island, which means it's far easier to quarantine successfully than when you have land boundaries. So we certainly could have done that as a way forward, but it clearly looks unlikely. Now that would have been my favoured way forward, but I will now tell you what my favoured way forward is, given that I think an elimination policy looks very unlikely from a government point of view. And this is an age-related policy. And this is based on a simple epidemiological principle, which is that whilst almost any age group can catch a disease, the consequences of catching the disease vary extremely greatly, particularly by age, such that if you catch a disease as a young person, let's say below the age of 20, you probably will be asymptomatic, and it is exceedingly unlikely that you will suffer severe morbidity or death. And indeed, it remains unlikely that you will have any significant mortality or morbidity up to the age of 40. The Public Health England report on this topic summarises the evidence clearly, and it's both UK and worldwide evidence. So if one compares the likelihood of dying compared to people at the age of 40, you are 27 times more likely to die if you're aged 60 to 69. You are 50 times more likely to die if you're aged 70 to 79. And if you're aged over 80, you are 70 times more likely to die than somebody aged 40. And of all the deaths which have occurred in the UK, by whatever measure, well, sorry, not by whatever measure, whether it's on death certificates or whether it is the main cause of death, over 95% of all the deaths in this country have been in people aged over 65. And therefore, there is a clear, I might almost say obvious policy, because I've been pushing for it for some time, and I'm yet to convince everybody about its utility. And yet we, only to a very limited extent, are showing a difference in our policy for people at different ages. We do have some rules for people aged over the age of 70 with particular underlying conditions. Indeed, those underlying conditions extend to people under the age of 70. And those people are being shielded. But those are really quite a small group compared to the number of people aged over 60 or over the age of 65. Now, if instead of the current policy, one had a policy of targeting those people over 60 and trying to ensure that they either worked from home or that they had adjustments made in their work situation, that they strictly adhered to the 2-meter rule, and that they had advice to take individual assessments of their risk, I think that there is every chance that people over the age of 60, who are generally more compliant anyway, would adhere to that stricter guidance, particularly because they could still carry out a lot of activities outside the home, outdoors. Now, at the same time, it would mean that for people under the age of 60, and clearly targeting people over the age of 60 is targeting a group who are, generally speaking, not economically active. And therefore, it allows the government potentially to have a policy which gives them the best balance between economically getting back to full health in the population and protecting the population as far as possible from having another spike of increased deaths. Now, I should just pause at this time just to say to people, if they aren't aware, that those conditions which now seem to have the greatest risk from the epidemiology are diabetes, hypertension, heart disease, obesity, and immunosuppression diseases. We also, of course, know that there are variations about the Black and minority ethnic groups, and those are particularly great in the Black and Caribbean communities, Bangladeshi and Pakistani communities. But the difference in risk is really quite modest, up to 4 times, including, that is, people who are older ages in those groups. And so those are very modest increases compared to the increase in risk of increasing age. And that is why the age-related policy is so likely to have an important effect if it was followed. So I've also speculated as to why there is resistance to such a policy being introduced. And I've come up with 2 behavioural theories for you to consider. The first I call the reluctance to admit vulnerability theory. And this theory is based on the assumption, which is generally true, that many people only reach their maximum hierarchy in their career, in other words, becoming the managing director or the consultant or the prime minister or the minister, etc., whether this be in business or in the professions or in politics. They generally have spent a lot of their life, if they're that way inclined, in climbing what I call the greasy pole. And often such people, I would suggest, don't want to admit vulnerability, partly because that means that that might expose vulnerability to their rivals, or it might mean that people seeing their vulnerability perhaps might take less cognizance of what they are going to say. To use a very simple example, could this be the reason why President Trump has never been seen to wear a mask in the United States? I suspect it probably is. So I think that's probably some of the reason why we aren't seeing this policy being enacted, because it would mean that some of the people leading our response would actually have to admit that they're vulnerable and might be perceived not to be able to carry out the full range of their duties. Now, the second view is what I call the inequity theory. And this is that it might seem unjust to people to have different rules just because they were more elderly. In other words, it's an ageist policy. And clearly, by definition, it is an ageist policy. And there is a potential problem in terms of equity. But it also exposes one of the problems that there is in public health terms, which we come across but may not be so well recognised amongst some of the audience on listening in tonight. And that is, with a communicable disease like COVID-19, one isn't just making a decision for oneself, but also for one's close contacts, particularly in your family. And therefore, let us say that there were 2 people aged 75, and one of them, having heard their risks, wanted to undertake more risky behaviour, and the other didn't. The problem is that because they live together, the actions of the person who wants to be more risky are highly likely to compromise the health of the other person who doesn't want to take the action. That's, of course, one of the reasons, loneliness was the other, why the government introduced the policy of the bubble, with single people, because that avoids some of that potential problem. So let me now perhaps turn on to some conclusions. I have given a tentative judgment on the performance of the UK in the first wave of the pandemic, and generally we've not done well. The public perception is correct. Government policy going forward is somewhat risky. It may succeed, but it risks a second spike. Obviously, the government's self-declared test that a second peak will not overwhelm the NHS is a very low hurdle, as we know much more about how to control the virus. And as I set out in my recent BMJ article, to say that a second peak should not overwhelm the NHS, that is a ridiculous hurdle, because nobody seriously thinks that we are likely to get another epidemic peak that is going to overwhelm us to the extent of another 40,000 deaths. Now, my hope is that new treatments and effective vaccines will mean that we can all meet together in person within a year of this talk. And clearly the welcome news about dexamethasone today means that we can be a little bit more hopeful. On the other hand, our surveys show that only about 7% of the UK population have had the disease, so clearly we can't be complacent. I should just add before ending that I have written extensively on many of the topics I've mentioned and quite a few other COVID issues. If you've been interested in those, you can email me and contact me, and I can perhaps share with you some of the emails and other communications I've written on these topics. But I'm now happy to close, and I welcome any questions. Thank you.
Myself again, unmuted. There we are. Okay, thank you very much. Now we've got a whole slew of questions that have accumulated for you. One of them is taking from a couple of them. One is about the New Zealand question, which I think you've addressed as to the resemblance between New Zealand. One is about Cuba, about the personnel testing method in Cuba, whether that would be applicable. One is why we don't have standardized international methods, why have standardized standardized methods been introduced. And one is that, is there comparison really between London, on the other hand, and New York, rather than a comparison between London and Europe in terms of the nature of the city? And the other comparison is with Sweden. What has happened with Sweden? Some people are asking whether they can see the questions. The problem about seeing the questions is that we're going to have to go off the screen from seeing you to see the questions. So I hope nobody minds my summarizing them. Oh, and there's one other one along similar lines. What's going to happen in winter? Is the winter fact going to be real? I've got to unmute you.
Sorry, I'll start again. So let me start off with contact tracing and standardization. There is a great deal of standardization across the world about how contact tracing should be undertaken, right? It's a very well understood and a very effective means of controlling an epidemic. Now, the problem in this country was the capacity that we had compared to some other countries. For example, Cuba has more capacity than us. And that's one of the reasons why I had a concern, and still have a concern, about so many inexperienced people being brought into the contact tracing system who aren't well versed in public health. And so that is one of the reasons why it may take some time for people to be able to carry out the system effectively. Because it's not easy to necessarily get people to cooperate fully with you and to tell you the truth about what they've been doing. So yes, there is standardization, but the particularity of what is happening in the UK means that we've got relatively few experienced staff, because many of the Public Health England staff who are experienced are doing other things in controlling the epidemic rather than being able to concentrate on the contact tracing. So we have a relatively limited number of people who are experienced in contact tracing in this country. Now, I don't think it is fair to compare us to the United States in coming to a summative judgment. That is because the United States is rare in having taken the view that, certainly at national level, that they didn't particularly want to institute lockdown measures. Now, clearly, there is quite a lot of power at state level in the United States, as I'm sure many people will realise, and therefore the experience in the States is very patchy, depending on what the states have done and when they did it. Clearly, some states like New York took action, but again, in retrospect, they would agree that they took action too late. Other states like California took action at a better time and have done better as a result of it. So it is difficult to easily compare ourselves to the United States, but the United States is one of the very few countries in the world where it is possible to make an argument to say that they've done even worse than we have in this country. Now, Sweden was somewhat unusual in that the epidemiologist who was the main advisor to the government was unusual in terms of saying that they wanted to have a relatively light touch lockdown, if I can put it that way. But having said that, in Sweden, the evidence showed that many of the public had already started to do social distancing even before the government issued any guidance. The other advantage that Sweden has is that it is of low population density, and that undoubtedly is a factor in the spread of the disease. It almost certainly accounts for the large epidemic we had in London and indeed the one experienced in New York. Having said that, there is some disagreement on how big an issue is population density. And so although I could have mentioned it in my talk, it is considered by most epidemiologists as a relatively minor factor and not one that we can use with much justification to explain our particularly poor performance. Now, the experience in Sweden and the epidemiologist there has had more opportunity to speak freely than has been the case with the medics and scientists in this country, unfortunately, who have to some extent been gagged, I'm afraid. Don't quote me, but probably that's not a great surprise to you in terms of what they've been allowed to say. But basically, the epidemiologist in Sweden accepts that in Scandinavian terms, Sweden is now doing worse than the rest of Scandinavia. And it's also the case that their performance in care homes has been poor. And therefore, he is already changing his views as in retrospect as to what he would have advised. So I think that clearly we are making a judgment now at an early stage of disease. And an advantage that Sweden may have is that a greater proportion of the population may have had the disease than the roughly 7% in the UK. And that may mean that Sweden, in due course, does better in the future. So that's one of the difficulties in making a judgment right now. And it could be that Sweden does better as we move forward, as we might need to get to the stage of herd immunity before we find a way out of this epidemic, although I'm personally reasonably confident that we will get an effective vaccine or get effective treatments, and probably a bit of both, before we reach the level of herd immunity. But that, of course, is just an educated guess.
With regard to guesses and numbers, there are two questions. One is that one question from Nicola was about life years lost as a calculator rather than deaths, and the other was about the R value. And the other one that comes up from your discussion about age is the schools policy. Should schools be closed, or should that be regarded as one of the changes that should be introduced?
Yes. Well, let me start. Oh, I am unmuted. That's good. Right. So let me start with the school policy. That was a question that I knew I was going to be asked, and so I didn't go into that so much in my talk. What I am advising to the BMA, it's not yet their policy, and indeed to the Faculty of Public Health, is, and indeed the Department of Health have also had this guidance from me as well, so a full house of guidance I've given. And what I've said to them is that my view, and it's not just my view, is that for children, the evidence is that, as I've already said, there is very little risk to the children themselves. Rarely, indeed, do they suffer any morbidity or mortality. It's also the case that there is no evidence of increased risk as a profession amongst teachers. And so I have reasonable confidence that we can protect teachers. We also know that the incidence of the disease is falling. And we clearly understand that there are social and educational problems in not having schools running. And those problems will affect people from underprivileged areas more than people from higher social classes. In other words, we're going to increase the inequity by not having schools open. And so for all of those reasons, I think that planning for a 1 meter rule for schools is justified. It is the right balance between risks and benefits. Yes, there will be a small increased risk, but I think personally that the benefits far outweigh the risks. So my view is that with an age-related policy, yes, you get, if you like, some additional restrictions in people who are aged over 60, but also you get some additional benefits in the younger age group because you can relax to the 1 meter. And indeed, I would also tentatively, if the incidence of the disease carries on to be falling, I would also say start planning for 1 meter, let's say from August, September time, for for businesses in the hospitality industry, etc., because that could make a lot of economic sense. Yes, there will be increased risk, but if the incidence falls, then I suspect that the risk-benefit ratio will mean that 1 or maybe 1.5 meters will be a prudent thing to do, as long as people age over the age of 60 and those with underlying conditions stick to the 2 meters. Now, there is also an issue about the weather and winter, as was mentioned before. It's all very well having a policy during the summer where it's relatively congenial to be outside. The problem is, and this is another advantage of another of my postulates of doing the maximal suppression idea and getting there by August, is that one has achieved it by the end of the summer. Because once winter comes, then it becomes much more difficult for people who've been used to doing things outside not to want to try to replicate those inside where the risk is far greater. And so there are very real risks as we move into the autumn and winter. Now, the R value, I think, was the next issue. And the R value is basically a metric which has been devised to try to measure how likely it is that the infection is increasing or decreasing. Now, there is a problem with the way in which that is reported in this country, in that they have taken out the figures from the hospitals and the care homes, which some of you might have noticed. And so what we're getting is an R value only in the community. That in itself should be a bit of a worry when we are so close to 1, because they've already taken out the 2 areas with the highest R values, right? One might also say, if one was being cynical, that they've done that deliberately to try to make people feel more comfortable with the situation. Now, the R value is not at all easy to measure, and it is actually a synthesis of many different models, plus some real data which occurs from repeated community epidemiological studies. But there will always be a range for the R value, which is why there is a problem when you have to quote a range. And of course, once you get to regional areas, the amount of information we have is relatively little, and therefore it makes the confidence levels wider when one goes to a regional level. So I'm not sure, I think I've probably covered most of the points. Were there any other issues you wanted me to cover?
And the other question was about life years lost.
Yes.
Rather than the death.
Yes. So clearly, life years lost is another way that one can and will look at it. And obviously, because this is a disease which predominantly kills people at the later stage of their lives, it does mean that in terms of life years lost, that will not be as great as for some other diseases, although most diseases predominantly kill people at later ages. But even if one took that as a metric, and I haven't seen any estimates of life years lost for this particular epidemic, there is no doubt that COVID-19 has been the #1 cause of deaths and of life years lost since March in the world. And nobody really believes that that is likely to change for another few months yet. You have to unmute again.
Unmute myself. There are a couple of final ones. One question is about vitamin D. The other is, do you think we're going to have false starts? People thinking we're going to have pandemics, false starts, and saying, we're going to be very cautious. It might be a pandemic when people get flu. And the other question, of course, is should we be pushing places of worship opening more quickly than has happened?
Okay, so 3 questions there. Let's start with vitamin D. So there is an association between vitamin D deficiency and mortality. It was being reported as early as May, but I use the word association advisedly. Not many people believe that this is a causative relationship. Now, it is true that there has been postulated a potential mechanism in that vitamin D might suppress the cytokine storm. However, most experts, and I would include David amongst them, and myself, do not think that vitamin D is a significant factor in the causation of the high mortality from vitamin D, right? And there is no evidence at the moment that giving vitamin D beneficially affects the clinical course of the disease. So that's what I would say about vitamin D. Now, in terms of, I don't know, crying wolf too early, whatever, yes, there is a risk that we may become overcautious in the future. There's a risk, but I would personally think it's prudent. I think the whole world will have become more anxious about the risks of novel viruses causing pandemics and will plan accordingly. I predict there will be greater stockpiling of PPE, and there will be at least an examination of this country on having more local capacity for both testing and the delivery and manufacture of PPE. Now, the world is also learning an enormous amount about the development of vaccines. And I think that this is likely to mean that we're going to be in a better position to more quickly develop effective vaccines should a novel virus appear in the future. So that's a relatively positive thing to say. Perhaps I should say, as the treasurer of the Faculty of Public Health, I also hope that an outcome will be that there'll be better funding of public health as a result of this pandemic. And then finally, I think there was a question about what are the implications for Jews and the worship of Jews. Now, solitary worship is allowed. Clearly, I saw a picture of Westminster Abbey, and I think there were 4 people in the whole of the Abbey who'd taken advantage of it, whereas shops were, you know, some of them were inundated with people. So, but solitary worship is allowed. Now, personally, I think that allowing groups back into synagogues would be really quite high risk. And I say that again because of the age structure of most Jewish communities, which is generally towards the elderly age group. And I should also say that there have been quite a number of studies about where have outbreaks occurred across the world. And there are quite a few quite well recognized outbreaks which have occurred in the Jewish community. And there have been ones that have occurred in weddings, bar mitzvahs, Shabbos services, not just in Israel, in Morocco, in a number of different countries. And so we know that there are risks involved. Clearly, one would hope that there would be social distancing in place, but I personally would be very cautious about restarting religious worship as we've known it because of the risks involved. But clearly, it's something that one would want to keep under review.
Well, Ellis, thank you. I think on the point of prayer, I think that is a good point to end up, and to say that I think I speak on behalf of everybody. Say thank you for a tour de force through a tour of many subjects, and explained extremely clearly and lucidly. It's as we said at the beginning, it's an introduction. And we're going to have sessions every Tuesday night ongoing for at least the next couple of weeks. This is just a taster that next week we have the patient experience. So we have a patient who will be talking about his experiences at the Royal Free Hospital, and we've also got Marcel Levy, who's not only a doctor but who's the chief executive of University College, who managed to publish a scientific paper on the subject of this during the course of the lockdown. But really, this is a huge thank you to you, and I presume you appreciate that this, of course, it's been recorded, so we're going to notify people that were unable to log in that they would benefit from listening to this. And I'm sure that they'll generate lots of questions to Hilary as well as to me, and I want to thank Hilary very much for all her help. Thank you.
Thank you.